Welcome back to the Deep Dive. Today, we're tackling a really specific topic.
We are.
We've got some very detailed revision notes you've shared, and we're going to use those as our guide.
Sort of our map, yeah.
Exactly. Our mission is basically to pull out the key information, make the technical bits make sense, and give you a really clear picture of atrophic vaginitis.
That's the plan. The notes cover, well, pretty much everything what it is. The causes, symptoms, diagnosis, management, all based on the source material.
And this is important stuff. It's pretty common, especially at certain life stages, and it can really affect, comfort and quality of life.
Definitely. Understanding it is valuable.
Okay, then let's unpack this. Where do we start? The definition, I guess. What exactly is atrophic vaginitis, according to these notes?
So the core definition, what the notes give us is it's inflammation.
Inflammation of the vaginal tissue.
Yes, and it happens because of reduced estrogen levels. That's the key.
Okay, estrogen.
Yeah.
How does having less estrogen actually lead to that inflammation?
Well, estrogen is really vital for keeping the vaginal tissues healthy. Think thickness, elasticity, moisture.
Right.
When those levels drop, the tissues get thinner, they get drier, less stretchy, and that fragility makes them, well, much easier to irritate and inflame. That's the vaginitis part.
And the notes call it vaginal atrophy sometimes, too.
They do, yeah. Vaginal atrophy captures that thinning aspect, the tissue changes.
Okay. And I saw other names listed as well. Genitourinary syndrome of menopause. Urogenital atrophy. Why those bigger terms?
That's a good point from the notes. It's helpful because while vaginal atrophy points just at the vagina,
Yeah.
genitourinary syndrome of menopause, or GUSM, acknowledges that low estrogen affects more than just the vagina.
Oh, okay.
It hits the whole lower genitourinary area, so the vulva, urethra, bladder too. Using those terms kind of highlights that related urinary symptoms often come along with it.
Got it. So it's not just a localized vaginal thing necessarily.
Exactly. The impact is broader, even though those vaginal tissue changes are central. But it all traces back to that drop in estrogen, like the notes keep emphasizing.
Right. Decreased estrogen is the root cause.
Absolutely. Leads to the tissue changes and, as the notes say, makes the area more prone to infections and other issues.
Okay, so that's the what. Let's talk why. What actually causes estrogen levels to drop like that? What's the etiology here in the notes?
Well, the number one cause listed is, no surprise, menopause.
Right.
But the notes also list other key situations. Things like having your ovaries surgically removed, oophorectomy,
Okay.
or certain medical treatments like radiation therapy or chemotherapy.
And what about medications? Did the notes mention any specific types?
Yes, definitely. Any medication that's designed to lower estrogen can trigger it. The notes specifically flag anti-estrogen treatments.
Like for breast cancer.
Exactly. Things like aromatase inhibitors are mentioned.
And it's not always prominent changes, is it? I think the notes mention temporary situations too.
Correct. Being postpartum, so after childbirth or while breastfeeding, those involve naturally lower estrogen levels temporarily.
Oh.
And that can cause symptoms, that fit this picture, especially vaginal dryness, which the notes really highlight as a key symptom linked to all these causes.
Okay. So given those causes, who is most likely to experience this? What are the main risk factors the notes lay out?
They line up pretty closely with the causes, as you'd expect. So anyone going through menopause or perimenopause is at higher risk because of that natural decline.
Makes sense.
Having had an oophorectomy or, like we said, undergoing those breast cancer treatments, radiation, chemo, hormone therapy, that significantly ups the risk.
Right.
Taking those anti-estrogenic meds, like the aromatase inhibitors, that's another key one listed. And interestingly, the notes also include smoking.
Smoking. It pops up everywhere, doesn't it? Fascinating. Okay, here's where it gets really interesting. The biology. How does it actually happen? The pathophysiology.
Yeah.
What's the step-by-step the notes describe?
Yeah, the notes give a pretty clear sequence. So with less estrogen, the vaginal lining, the mucosa, it gets thinner.
Okay.
It also loses that natural stretchiness, that elasticity. And estrogen also helps keep good blood flow going to the area, and it's involved in making natural lubrication.
Right, lubrication is key.
Definitely. So less estrogen means reduced blood flow and significantly less lubrication. Put all that together, the thinning, the lost elasticity, less blood flow, the dryness, and that results in that chronic inflammation and discomfort people feel.
Wow, okay. So it's like a domino effect.
Yeah.
Starting from that estrogen drop. Now, if someone presents with symptoms like that, dryness, irritation, discomfort, what else might be going on? What does the differential diagnosis section in the notes say to consider?
Yeah, this is super important clinically because symptoms can overlap quite a bit. The notes break it down well. First off, you absolutely have to think about other things causing vaginal inflammation.
Like infections.
Exactly. Infections are a big one. Common culprits like yeast infections, bacterial vaginosis BV, or STIs like trichomonas, those need ruling out.
Any non-infectious things listed?
Yeah. The notes mention inflammatory skin conditions that can affect the vulvar. They call them vulvar dermatoses. Lichen sclerosis is given as an example.
Okay.
And also allergic reactions or just simple irritation. Could be from soaps, bubble baths, even laundry detergent on underwear or panty liners. Lots of potential irritants.
And the notes mention something about pH levels being helpful.
They did, yeah, that's a useful clinical nugget. Atrophic vaginitis often leads to a higher, more alkaline vaginal pH. Specifically, the notes say greater than 5.
Okay, pH over 5.
Which is different from the normal, more acidic environment. Now, the tricky bit the notes point out is that some infections, like trichomonas and BV, also cause a higher pH, often above 4.5.
Ah, right.
So while a pH over 5 makes you think strongly of atrophy, a high pH generally means you still need to rule out infection properly. And importantly, the notes say atrophy itself can actually make you more susceptible to infections.
So you could even have both at once.
Potentially, yes. So that pH is a clue, but not the whole story.
Good distinction. And the notes also mention other things to rule out, like postmenopausal bleeding causes or diabetes affecting things.
Exactly. If someone has postmenopausal bleeding, that always needs investigating separately. And uncontrolled diabetes can sometimes cause or worsen vaginal or urinary symptoms, so that needs considering too. It's about the whole clinical picture.
Right. Okay, shifting gears slightly, how common is this? What do the notes say about epidemiology, especially in the UK context they mention?
Well, the source material confirms it's definitely more common in postmenopausal women, which fits with everything we've said about estrogen.
Hmm.
But interestingly, it specifically highlights that there isn't much readily available specific UK data on exactly how prevalent it is.
Huh. So we know it's common in that group, but maybe the precise numbers aren't pinned down in the material provided. Okay, let's get into what it actually looks and feels like. Clinical presentation symptoms and signs. What do the notes list?
The symptoms described are pretty characteristic. Top of the list are things like vaginal dryness, irritation, itching, maybe a burning feeling.
Okay.
Painful sex dyspareunia is also really common. That's down to the lack of lubrication and the thin tissues. General discomfort or pain in the area is listed too.
And the notes mention the tissue changes themselves.
Yes, they reiterate that feeling of thinning and loss of elasticity. And sometimes, because the tissue is so fragile, there might be a bit of light spotting or bleeding, especially after intercourse.
The notes really hammered home the dryness point with a stat, didn't they?
They really did. Vaginal dryness is specifically called out as the most common symptom. The notes say up to 93% of women with the condition experience it.
93%. Wow.
Yeah, and of those, it says 68% report it as moderate to severe. So it's not just present, it's often quite bothersome.
That really emphasizes the impact. And thinking back to GUSM, it's not only vaginal symptoms, is it?
No, exactly. The notes detail those related urinary symptoms too. Things like needing to pee more often, getting up at night to pee nocturia, painful urination, which is dysuria, recurrent UTIs, sometimes stress incontinence, or that feeling of urgency, like you really have to go right now.
That affects bladder function, too.
Yes, and the notes also mention the impact on sexual function, things like decreased arousal or desire, even trouble reaching orgasm.
So it really touches on daily comfort, bladder, sexual health. Quite wide-ranging. The notes also made a point that some women might have the tissue changes but not actually feel symptoms.
That's true. It's possible. And related to that, there's that really important point about how difficult it can be for women to bring up vaginal dryness. It might be underreported because of that reluctance to discuss it.
That's a huge clinical point.
Right.
Okay, what about signs? What might a doctor or nurse actually see during an examination?
Right, the signs. Externally, the notes mention things like maybe reduced pubic hair, the skin might seem less firm or elastic, and the opening to the vagina, the introitus, might look a bit narrowed.
And looking inside with the speculum.
The vaginal lining, the mucosa, often looks thin. It might have a general redness erythema. Because it's fragile, you might see tiny red spots, which are called petechia, or even small bruises, ecchymosis.
Okay.
A really key sign is noticeable dryness and the absence of those usual folds, the rugae, in the vaginal wall. And sometimes, the notes mention, you might see signs of prolapse, maybe the urethra or the vagina itself dropping slightly.
And the exam itself could be uncomfortable for the patient.
Yes, the source material makes a point of saying that, understandably, the examination can be uncomfortable or even painful because the tissues are so sensitive and dry.
Makes total sense.
Yeah.
Okay, so with those symptoms and signs, how is the diagnosis usually made? What investigations do the notes talk about?
The notes state pretty clearly that the diagnosis is mainly clinical.
So based on history and exam.
Exactly.
Yeah.
A good history of the symptoms, combined with a pelvic exam looking for those signs we just discussed, that's usually enough.
Are there specific tests mentioned that could help confirm or rule other things out?
Yes, vaginal pH testing comes up again. That pH greater than 5 is suggestive. And vaginal swabs or cultures are mentioned, but mainly if you suspect an infection is going on.
Okay.
But the notes add a bit of nuance. Investigations aren't always needed if it seems clear-cut clinically. They're more for ruling out other possibilities.
Like if there are confusing symptoms.
Right, or particularly if there's any postmenopausal bleeding that always needs further investigation. Or to definitively rule out infections, or check for underlying things like diabetes if suspected.
And vaginal cytology was mentioned briefly too.
Yes, it's listed as something that can be done. It would show a lack of mature cells in the vaginal lining, which fits with atrophy.
Okay, so once it's diagnosed, what about management? What's the typical approach outlined in the notes, especially thinking about that UK context they reference?
The notes lay out a nice kind of stepped approach. First line, especially for milder symptoms, is using non-hormonal options.
Like what?
Vaginal moisturizers used regularly and lubricants used during intercourse, just for symptomatic relief.
And if those don't quite cut it?
If symptoms are persistent or more severe, then the notes really point to topical estrogen therapy. That's considered the primary medical treatment.
Delivering estrogen right to the source.
Exactly. It comes in different forms: creams, little tablets, or rings that are inserted into the vagina. It works locally on those tissues.
Are there other sort of non-medical things suggested?
Yes, the notes mention that keeping up regular sexual activity or sometimes using vaginal dilators can actually help maintain elasticity and stop things from narrowing too much.
Interesting.
And general lifestyle things too, avoiding irritants like harsh soaps, wearing cotton underwear, that sort of thing. Good hygiene practices.
The notes also mentioned wider hormone replacement therapy, HRT.
Correct. Systemic HRT, the kind taken for broader menopause symptoms like hot flushes, the notes say that's also effective for atrophic vaginitis.
Oh.
It helps restore the vaginal pH, improves lubrication, and can help with those urinary symptoms too. But the notes do emphasize that the topical estrogen treatments are generally very well tolerated because the dose is low and stays local.
How quickly does it tend to work?
They give a time frame, usually see the maximal benefit within about 1 to 3 months of using it consistently.
Okay. Any important warnings or caveats in the management section?
Yes, a couple of really crucial ones. First, any woman using hormonal treatment, whether topical or systemic, who experiences unexpected vaginal bleeding must see their doctor. That needs checking out.
Right, absolutely.
And second, if the vaginal symptoms don't get better, even with hormonal treatment, then it's really important to think again. Reevaluate the diagnosis, look for other causes, go back to that differential diagnosis list we talked about.
Those are key clinical points. The notes also briefly list a few other things: laser, progesterone, ospemifene.
Yeah, they get a mention, but the notes basically say their use kind of depends on specific guidelines and patient factors. The focus is really on those core strategies: moisturizers, lubricants, and topical estrogen.
Got it. Okay, finally, prognosis. What do the notes say happens over time? What's the outlook, with or without treatment?
This section has a really, really key distinction, probably one of the most important takeaways from these notes.
Okay.
The notes explain that vasomotor symptoms, so hot flushes, night sweats, they do tend to get better on their own over time, usually within maybe 2 to 5 years after menopause, although it varies.
Right, they often fade eventually.
Yes, and HRT is great for managing them in the meantime, reduces them significantly, helps with bone health too. But, and this is the critical difference for atrophic vaginitis, the genitourinary symptoms, that vaginal dryness, the irritation, the itching, the painful sex, the notes are very clear. These do not tend to improve over time by themselves.
Well, really, they just persist.
They're likely to persist, yes. And the notes specifically say they may well come back if treatment, like topical estrogen, is stopped.
Wow. Okay. That is a vital difference. So unlike hot flushes that might go away, the atrophy symptoms often need ongoing management.
That is precisely the core message on prognosis from this source material. It's often a chronic condition in terms of those specific symptoms needing ongoing attention.
So what does this all mean? We've really dug into these detailed notes on atrophic vaginitis. We've covered the definition inflammation from low estrogen. We looked at the causes, the risks, how the tissues actually change.
Yeah. The pathophysiology.
Right. How to tell it apart from other things, the symptoms and signs, diagnosis, and those management steps, moisturizers, lubricants, and especially topical estrogen.
And that key point about prognosis.
Exactly. That crucial difference highlighted in the notes, unlike some menopause symptoms, the dryness and discomfort from atrophy often stick around and need ongoing care.
And understanding all that from the notes really gives a clear framework. It shows why spotting it is important and that there are effective ways to manage it and improve quality of life significantly.
Definitely. And maybe a final thought for you listening, thinking back to that note about how hard it can be to discuss vaginal dryness.
Yeah, that reluctance.
Maybe just consider the impact of opening up that conversation, whether it's with your doctor, your partner, even a friend. Talking about these symptoms, as the notes implicitly suggest, is really the first essential step towards getting that understanding and the effective help that's available.
That communication piece is just huge. It really can make all the difference.
Well, thank you for joining us for this deep dive into atrophic vaginitis, guided by the notes you provided. We hope this breakdown has been clear and valuable for you.
It was a good set of notes to work through. Definitely highlighted the key areas.
Until next time.